main action of vitamin D is to promote calcium absorption in the gut. Vitamin D insufficiency probably is a term that we shouldn't use anymore. The evidence that vitamin D reduces fractures with or without calcium is weak in the general population, maybe strongest in the elderly that have true deficiency. It does not prevent other diseases. I suspect we should not be screening individuals for vitamin D levels in routine primary care, but may be appropriate in patients at risk for vitamin D deficiency, such as GI diseases, inflammatory bowel diseases, chronic liver disease. But beyond that, I think the benefits are not really accessible with vitamin D supplementation. So with that, I'll stop, and I don't know if we have time for questions or not, Anne, but
we do. Let's. This is such an important topic. Let's take 5 minutes and do some of those. So thank you so much, Cliff. There's so much food for thought. I was gonna make some pun about the food and the fortified food for thought, but not quick enough on my feet. So I'll go straight into the questions here. We have one about cancer maybe being missing from your list of chronic conditions.
Oh yeah, no, in New England Journal last year or 2 years ago, there's a paper from the VITAL trial which showed no reduction in risk of cancer, all cancers, any cancer, with vitamin D supplementation, 2,000 units a day. So, and that was the 5-year study of 26,000 individuals. So, no evidence for that. Dr. Manson has maintained that there might be, in individuals after the first year of treatment, there might be a reduction, but that was not a hierarchical secondary outcome. And so it's more hypothesis testing.
Mm-hmm. And ovarian cancer in particular, this audience member points out a systemic review did suggest that maybe there would be something there, but I haven't read this.
Certainly nothing in VITAL, which is the longest thing. And I caution you about the systematic reviews, that they're relatively small, and the randomized trial is probably the best. The other thing is, I didn't show it, but the Australian group did a long-term study of mortality with vitamin D supplementation in a large cohort and found absolutely no decrease in mortality with vitamin D.
Yeah. The next question is about how to address patients in our clinic. The audience member writes, how about patients with secondary hyperparathyroidism and vitamin D levels between 20 and 30 nanograms per milliliter with reasonable calcium intake, no hypercalciuria? This person says that there are so many cases in their clinic, and PTH levels do come down some with higher 25 hydroxy.
Yeah, I just think that you probably can get some decline in PTH in those secondary hyperpara patients between 20 and 30. I'm just not sure that the outcome means anything. And of course, one has to adjust for a couple of things: phosphate in your diet, phosphorus in your diet, and of course, renal function, which affect PTH dramatically. So yeah, I think you give enough vitamin D, you can suppress PTH, but the question is, does that mean anything? And maybe in osteoporotic individuals who have bone loss and show an increase in bone turnover, I suspect if you could show that the 25D suppressed CTX and PTH, you might have a better case. I just don't see it in our studies.
Although the safety implications with medications, if you let's say that you had a postmenopausal woman with osteoporosis, right, whose 25 hydroxy vitamin D level was 21, and you wanted to start alendronate, what would you do with respect to vitamin D?
Right. So that's a great question. Steve and I went back to to one study that was done with Fosamax plus D versus Fosamax alone. Remember, I don't know if people remember this, but they were Merck was hawking Fosamax plus D, as an easy way to get your D. And there was no difference in bone mineral density in the combination. I think it's 7,200 units in the vitamin D plus Fosamax group. So, it's about 1,000 units a day. I just don't see that happening. But of course, there's no reason not to. I mean, to give a low dose of vitamin D, 400 units or 600 units, that's reasonable. It's just that there's no evidence it really does anything, and there's no trial that's ever going to show that because nobody's going to do a placebo-controlled trial. The other thing I should point out is when I say 400 units, from the Chapuis study and other studies, the lower your 25D is, the better you'll have an effect. So 400 to 600 units will get you to 30. Mm-hmm. Whereas if you start at 30 and you get 400 units, you're not going to change your vitamin D. Mm-hmm.